We'll be knowing what are the factors that are affecting cardiac output and how cardiac output is regulated. First, let us learn what is cardiac output. Cardiac output means the amount of blood ejected in circulation from ventricle during each beat or during in 1 minute. If it is during each beat, we want to know the amount of blood ejected into circulation by each ventricle during each beat. Then it will be called as stroke volume. When we want to know how much blood is ejected into circulation by the ventricles in 1 minute, then it will be termed as cardiac output also. It is minute volume. Cardiac output is defined as the amount of blood pumped out of the ventricle per minute. Cardiac output is expressed in two forms. We have also discussed earlier. One is stroke volume and another is minute volume. Stroke volume means by each beat, each beat, how much blood is ejected into the circulation by each ventricle. Okay, so what is the amount? Normally it is 70 ml. And if our heart rate is, suppose our heart rate is 70 beats per minute, then what would be the minute volume? 70 each time into 70 times 4.9 liter, 4900 ml, that is 1.9 liter. So this is the cardiac output in liter per minute. So let us see, then minute volume, it depends on two things. One is stroke volume, another is heart rate. If heart rate is increased, then minute volume is going to increase. So since cardiac output is the product of both, so if it increases, then cardiac output will be increased. If stroke volume is increased, then also cardiac output will be increased. Since they are the product of cardiac output is the product of SV, stroke volume and heart rate. Normal heart rate is 70 beats per minute or 72 beats per minute. Actually, it ranges from how much? 60 to 80 beats per minute. So, and average stroke volume is 70 to 80 ml. Average or range, normal range is 70 to 80 ml per beat. It is the stroke volume. So it may be 70 ml, it may be 80 ml. So average cardiac output will be 5 liters per minute, 5000 ml per minute. In case of athletes, if you do severe exercise, your heart rate will be increased, at the same time your stroke volume will be increased. As a result, during extreme exercise, at the end of the extreme exercise, your cardiac output, minute output may go beyond about 20 liters per minute. And those are highly trained athletes, say for example marathoners. Okay, their heart rate, their cardiac output may increase up to 35 liters per minute. So their heart is very strong. Their heart rate can be increased do you know what would be your maximum heart rate? Normally it is 70 to 80 beats per minute. So how much it can be increased? Definitely it will be increased during exercise. How much it can be increased? Any idea? We can predict it. There is a simple formula, you will get it in future. This formula is 220 minus age. 220 minus your age. Now you predict what would be your maximum heart rate. So amateur maximum heart rate is 220 minus your age. Okay, so while somebody will be performing exercise on a treadmill for TMT tests, whether he is having any cardiac disease, ischemia or like that disease that we want to diagnose during TMT testing. So during this testing, we fix, he has to work, no? How long he will work? till the heart rate achieves that target heart rate. What is the target heart rate? 220 minus the age of the patient. So he will be running on the treadmill up to that target heart rate. If anything happens, it will be happening during this time. So if there is any ischemia or infarction, whatever the cardiac abnormality that can appear during this event. Let us see. Normally, how much blood is ejected? 5 liters of blood in 1 minute. Where these 5 liters of blood is going? In which organs these are going? And every organ is getting a part of the cardiac output, part of 5 liters. Now see which part gets how much. Liver gets 1 out of 5 liter. Liver gets how much? 1500 ml. And this is the 30% of the total cardiac output. And in case of kidney, how much it gets? Kidneys get the 25%, that is 1300 ml. Skeletal muscle, it gets 900 ml, it is about 18%. Brain gets 800 ml out of 500. This is their part. This is the portions they will be getting out of from in every minute. In every minute, the 5 liters of blood coming out. How much they will each organ will be getting, that is described here. So heart gets 200 ml, 200 ml. Heart means in coronary circulation, not in its cavity. So heart rate already ejected this 5 liters of blood, and part of this blood from the aorta is coming to the coronary circulation. How much is this? That is 200 ml. How much? What is the percentage of this? It is the 4% of 5 liters. Okay. So next, let us see. Remember, we have at the beginning we told that what are the factors that are controlling that will be affecting cardiac. So these are the factors. What are the factors? Number 1 is age. So we have seen. See, a child, an infant or a child, what do we expect? What would be his cardiac output? More or less, his heart rate is more. Then you may say his cardiac output will be more, but his or her heart size is also less, and stroke volume is also less. As a result, cardiac output will also be less than 500 ml. Okay, so in elderly person, in our case, it is around 5 liters. Okay, next question is gender. So heart size of girls is lesser than the males. So that means their cardiac output, their stroke volume will also be less. Okay, so as a result, cardiac output will be less. And then altitude, cardiac output increases at high altitude. Those who are staying at high altitude, their cardiac output is more. Pregnancy, during pregnancy, heart rate is increased. As a result, stroke volume remains same. As a result, increased heart rate, stroke volume remains same. As a result, cardiac output will be more. And during exercise, we have seen during exercise it may increase up to how much? Up to 18 liters. It may increase up to 18 liters at extreme exercise. And in case of athlete, it can go up to 35 liters per minute. And emotion, when we are we become emotional. That means when we are having excitement or agony, in that case, having tension, what that happens during heart rate is increased. Yesterday also we discussed heart rate is increased, and this is affected by the cerebral cortex, limbic system, hypothalamus. So they increase the heart rate. So if heart rate is increased, if the stroke volume remains same, then also cardiac output will be increased. So emotion is also important factor that affects cardiac output. Posture. What happens if you suddenly takes the erect posture. You had been in supine position and suddenly you are taking the erect posture. What will be? There will be dizziness. Why? Less blood will be supplied to the brain. Why blood supply? Because gravity will pull. While you are standing, the gravity will pull your blood downward. As a result, sufficient apron. What will happen? Your cardiac output is decreased. But our body instantly takes action. Instantly, by reflex action, it increases the heart rate. So that's why you see while you are sitting or lying, see your pulse rate, and while you will be in erect posture, you will see your pulse rate. It is increased. So by increasing the heart rate, you maintain the cardiac output, and thereafter no dizziness. You become normal. Okay. So this is the compensatory mechanism. The posture. So what are the factors? Age is one of the factors, and gender is another factor. Altitude is another factor. Pregnancy, exercise, emotion, sleep, posture. So these are the factors that affect cardiac output. Now, what are the conditions? What are the conditions in which cardiac output is increased and decreased? So these are the conditions, variation of cardiac output. One is pathological variation of cardiac output. Here it is the pathological, but it increases cardiac output. Here pathological, but it decreases the cardiac output. So what is the conditions? Hyperthyroidism. We have learned during hyperthyroidism more thyroxine is secreted, and this thyroxine is catabolic in nature. It catabolizes the carbohydrates. So means it requires more for catabolism of carbohydrate, for generation of energy. It requires more oxygen. Who will be supplying this oxygen to the tissues? This will be supplied by the blood. That means the tissues will require more blood. So how this more blood can be sent to by increasing the heart rate. So if there is increase in heart rate, what will be there? If heart rate is increased, then cardiac output will be if stroke volume, if both or either of one increases, then cardiac output is going to increase. So in this case, in hypothyroidism, increased thyroxine will cause tachycardia. Means there will be increased heart rate. As a result, this increased heart rate into stroke volume, cardiac output will be increased. So this is the cause of hyperthyroidism. In hyperthyroidism, cardiac output is increased. In fever, also we know heart rate is increased. So because of increase in heart rate, cardiac output will be increased. In anemia, we are supplying anemia, less blood, means less hemoglobin, means its ability to supply to the tissues is less, supply of oxygen will be less. So heart will try to send more blood to the tissues to get this oxygen. So as a result, in anemic patient, cardiac activity will be increased. Because of this increased cardiac activity, there will be increase in cardiac output. Now let us see what happens in pathological disease. So here hyperthyroidism, we have seen there is increase in cardiac output, and in hypothyroidism there will be just opposite. There is less production of thyroxine, so means less catabolism. So that means we require the patient will be requiring less oxygen, means less blood. So that's why heart has to beat less. Okay, so in that case, you will see decrease in cardiac output. Hypovolemia means there is blood. We are having how much of blood? How much blood one can have? Total. What is the blood volume? 5 liters. Okay, we are about 5 liters. So, if by hemorrhage or by any other means blood volume is decreased, that condition is called hypovolemia. So hemorrhage is one of such example. During hemorrhage, lot of blood will be lost and there will be hypovolemia. In hypovolemia means less blood. So this oxygen is required by every cell, but blood is less. Then previously it was 5 liters per minute. Now it is less. So supply of oxygen will be reduced. So now the heart, the mechanism will try to send more blood, to the tissue to supply oxygen. As a result, heart rate will be increased. In shock also, there is a decrease in cardiac output. In myocardial infarction, there is a decrease in cardiac output. Atrial fibrillation. In atrial fibrillation, repeatedly atria is contracting, but ventricle is not contracting. As a result, cardiac output will be very less. And in congestive heart failure, heart is congested with blood, but in the periphery there is lot of resistance. Its power of contraction is less. As a result, there will be less stroke volume, so cardiac output will be less. So these are the pathological variations of cardiac output. Now, these factors affecting cardiac output, that means what are the factors that will be regulating our cardiac output? These are the main 4 factors that will be regulating our we will be studying the regulation. So we will find these are the 4 main factors. See, what are these? Heart rate, force of contraction, blood volume and venous return. So you see, venous return, heart rate, peripheral force of contraction, blood volume also there, blood volume and venous return. These are the important factors. So the factors that is going to affect the stroke volume will also affect cardiac output. Similarly, the factors that is going to affect the heart rate, that will also affect our cardiac output. So if these factors, they are controlling heart rate. So if any one of these, they can increase or decrease the heart rate. As a result, this heart rate can be increased or decreased. Here also, the stroke volume can be increased by decreased by these factors. As a result, there will be change in stroke volume. So when we multiply this, the stroke cardiac output may be increased or decreased. So these are the factors. Means the factors that are affecting stroke volume also will be affecting cardiac output. The factors that will be affecting heart rate, that are also going to affect the cardiac output. Okay, now we will discuss how these are regulated. Okay, one more thing you must understand. One is end systolic volume and one is end diastolic volume. Heart is relaxing. So it is now maximally relaxed. Now how much blood is there? This blood is called maximally dilated. Now this amount of blood is called, the volume of this blood is end diastole. So this is the end of diastole. During condition, how much blood is there? So this is the end diastolic volume. And what is end systolic volume? Now the ventricle will be contracting, burst that much. Okay. So now what is the volume? It is the systole. So now some blood will be there. This is the end systolic volume. So it is end diastolic volume, end systolic volume. And if you subtract this volume from this volume, then what will get? Stroke volume. Where this blood has gone to the circulation, and it is during each beat how much blood has gone? This is the end diastolic volume minus end systolic volume. So this difference is actually the stroke volume. Then what is stroke volume? Stroke volume is end diastolic volume minus end systolic volume. Is that clear? Is that clear to you? End diastole, now it will be contracting, certain amount of blood came out, this is stroke volume only, and some blood retained within the ventricle, this is the end diastolic volume, end systolic volume. So what is the stroke volume? End diastolic volume minus end systolic volume. Understood? Is that clear? Right? Fine. Regulation. See, regulation of stroke volume, we have already discussed. The factors that regulates stroke volume also affect cardiac output. Now let us see, here are three important factors that affect stroke volume. What is this? One is end diastolic volume, another is afterload, total peripheral resistance, another is contractility. Let us understand this. What is this? The first one, end diastolic volume. We have seen this is the end diastolic volume. End diastolic volume, volume of blood in the ventricles at the end of diastole. This is also called preload. Preload. Before contraction, this is the load to the ventricles. Before contraction, before systole, it is the load. Okay, this amount of load it has to send into the aorta. So if the load is more, heart has to work more. It needs more force of contraction. Now, how much force has to be generated? When there you will find one law, Starling's law of heart, right? Starling's law of heart. So you may get MCQs on that. What is or short question or explanation, reasoning. Starling's law of heart, very important question. What is Starling's law of heart? Okay, now if ventricular filling, let us explain. In one case, look at me. In one case, heart is relaxing, ventricle is relaxing. What is happening? From auricles, blood is entering. So certain amount of blood is there. Okay. So because of entering relaxation, the ventricular, because of the blood in the ventricles, the wall, the cardiac muscle will be stressed. How much it is stressed? Okay. In another condition, another heart, during relaxation, it has relaxed this much. Where volume is more, in the second case volume is more. In one case, heart is relaxed up to this much. Less blood entered, less stretching of the muscles. Okay. In another case, more relaxation, more entry of blood into the ventricles, more stretching. Now, where the force of contraction will be more? In this case or in this case? In the latter case. Why? The muscles are stressed more. You just think about bow and arrow. So if you stress it more, then force will be created much more. So here also, if cardiac muscles are stressed more, then it will, during contraction, it will create more force. Means more blood will be coming out. Okay, so this is one of the important factors that will determine the stroke volume. So ventricle has to generate force. How it will be, how much force it will be generated? It will depend on how much it has been stressed during diastole. That is why end diastolic volume is very important. So you can think, in the patient who are having more end diastolic volume, they are able to create more force. There is more stroke under normal condition. They can create more stroke volume. They can, during contraction, they can create more force, more stroke volume. As a result, this thing, more stretching means more preload. Why more stretching? More expansion, more blood in the ventricles. So more blood, more venous return means more stretching means more force of contraction, means more cardiac output. So in this way, this stretching, this is called preload. End diastolic volume, it is also preload, and stretching, this made by this blood, is also preload. So preload will be determined. It will be determining how much will be the stroke volume. Is that clear? Preload. So you may get question about preload. What is preload? Preload affects cardiac output, stroke volume. Explain. Preload affects stroke volume. Explain. Okay, so this sort of question you can get. How preloads is different from another afterload. So we will get two loads. One is preload. Preload you understood. And now what is afterload? Okay, now ventricle preload is there, ready to contract. How much contraction will be there? Suppose I am ventricle, ejected some amount of blood. He is in aorta, he is the blood. Ejected this blood is already in aorta. So I am from ventricle ejecting more, this 70 ml of blood. Now what if this 70 ml of blood will push him and he will go forward. Now if in presence of, in his front, there are some other persons. Here nobody is there. If there are 5-6%, then if I am to push him, then I will be needing more force. I will be needing force. So this is the resistance. This is the resistance. I have to overcome. By pumping, I have to overcome this resistance. Go. I have to overcome this resistance. Okay, this resistance is called, this resistance is where? In the aorta, in the arteries. So this over the, where I will be sending it? To the aorta. But the aorta, there is already some blood is there. So they will be obstructing. Why they are there? Because of the peripheral resistance. So I have to overcome this peripheral resistance. Then we will be able to send all this blood into the circulation. So this is the afterload. This resistance is the afterload. If afterload is more, it has to create more force. It has to overcome those resistance. Then it will be possible to enter the blood into the circulation. So stroke volume will depend on pre-load and afterload. Can you explain this? Preload, more stretching, more force of contraction. Understood? It is stretched more. Now it will be contracting with more force. But who is there at my front? Where I will be sending this blood into the aorta? So if there is more resistance, then it will not be possible for me to send all the blood there. If I want to send there, I have to create more force. So it will depend, stroke volume will be depending on peripheral resistance and also distensibility, or how much the ventricular muscle has distended. So this is preload, that one is afterload. Okay, and the contractility. Contractility is strength of the ventricular contraction. Stroke volume increases the contractility. If the stroke volume is more, that is, it has stressed more, so this will be contracting with more force. So this is if the muscles are having, say for example, suppose I had a heart attack. Okay, some portion of my ventricular wall was initially damaged. Then I survived. Why I survived? Because this portion got blood supply from other coronary blood vessels. Then this portion regenerated. But not by most of the cells are not myocardial cells. Most of the cells will be by fibrotic cells. These fibrotic cells are not having contractility. So after the survival, this area is replaced by fibrotic tissue, and this fibrotic tissue are not having contractile power. As a result, in my case, what force of contraction I used to generate, now I will be able to generate less force of contraction because of this. This area will not be able to generate force because they are not muscle, they are fibrotic cells. So in such case, the contractility of the ventricle is less. It may be stressed more, but it cannot, since this area cannot contract, so the ventricle will not be able to generate force, generate cardiac output, stroke volume as earlier. So what are the main One is preload, another is afterload, and the strength of or cardiac muscle contractility. Ejection fraction average. In any echocardiography report, we want to know what is the ejection fraction. Means how much blood you are. This is the end diastolic and end systolic volume. This much. Out of this, how much you can eject into this. If the heart is having more power of contraction, more stroke volume will be there. So what percent of stroke volume is? What percent of EDV, end diastolic volume? So stroke volume divided by EDV is the ejection fraction. Ejection means this much blood after EDV, end diastolic volume. So out of this, how much blood you could eject into the circulation? Okay, what is the percentage? So if it is, suppose if it is 120 ml and out of this you could eject only 60 ml. So what will be the ejection fraction? 60 by 120. What is the percentage? 50%. So your ejection fraction will be 50%. Normally it is how much? 50 to 65. When ejection fraction is less than 50, then means your heart is losing strength of pumping. Your pump is poorly performing. And if it performs 70%, that is your pumping action is very nice. The muscles, ventricular muscles are very powerful. But when it is coming down to less than 50, it means your muscles, ventricular muscles are not up to that having capacity. It is pumping action is deteriorating. Regulation of cardiac output, mechanism of regulation of cardiac output. So these are the 6 factors, and other factors also there. So mechanism of regulation of cardiac. What are these? Main 4 factors. One is venous return, force of contraction, heart rate, peripheral resistance. And there are other 2 factors, neural factors. Actually, these neural factors affect heart rate. These neural exhibit its action through changing heart rate. And hormonal regulation, particularly the adrenaline, secreted from adrenal medulla. When we become excited, the secretion from adrenal medulla, secretion of adrenaline is more. So they have action on SA node, on AB node, atrial muscle, ventricle. As a result, the cardiac activity is increased. Okay, so if heart rate is increased, force of contraction, cardiac output will be increased, stroke volume will be increased by the hormones. So it is simple. We have seen thyroxine can increase the heart rate. If thyroxine can increase the heart rate, this increased heart rate can increase cardiac output. Okay, so thyroid hormone can also regulate or increase or decrease cardiac output. Let us discuss first one, venous circulation. So here we will find, you try to here the regulation of cardiac output. What are the main factors? Venous return, heart rate, peripheral resistance, force of contraction. Write it down. Force of contraction, neural factors, and it is having sympathetic parasympathetic will come, and then hormonal factors. So these are the main 6 factors by which we regulate our cardiac output. Now let us discuss about venous return. Again, this venous return. Again, this venous return is affected by so many factors. What are these factors? And 9 factors. There are 9 factors. Mr. Carr purchased. What purchased? Went to V2. V2 is a shopping mall. Went to V2 and purchased 4 bags. A lot of bags. Okay, so what is the Mr.? M stands for muscle. I will explain. One is muscle pump. Muscle acts also as a pump. One is muscle pump. R, respiration, breathing. So this will also be affecting venous return. We will explain. Mr. Car, cardiac pump. Car means cardiac pump. Mr. Car went to B2. B2, B2, two B's are there. Okay, one B is ventricular compliance. This spelling mistake. Plance. Compliance and venous pressure. B2. One B is venous pressure, another B is ventricular compliance. Okay, so B2. What they Mr. Carl purchased? Bags. B for blood, total blood. Okay. A for AV difference of pressure. Arteriovenous pressure difference. Arteriovenous pressure difference. And G for gravity. S for what? Sympathetic tone. Sympathetic tone, and it is ventricular compliance. Venous pressure. So there you will find there are 9 factors. 9 factors that affect venous return. Since all of them can affect venous return, they can also affect cardiac output. We have seen these are the factors they affect cardiac output. Now, this factor can affect cardiac output, we know, but this one is dependent on this. So they can also affect venous return and thereby it can affect cardiac output. Is that clear? Okay. Now let us see one by one. Respiratory pump. Let us discuss respiratory pump. What happens during inspiration? Your thoracic cage expands, diaphragm descends. What happens? Expanded, diaphragm descended. As a result, thoracic volume increased, volume of the thorax increased. Pressure will be decreased. We know when there is increase in pressure, there will be reduction in pressure. Increase in volume, reduction in pressure. So, in the thoracic cavity, there is less pressure. Then what is the effect? In the heart is, where heart is located? In the thorax. Superior vena cava, inferior vena cava, where they are located? In the thorax. Now, if the thorax is having less pressure, what will happen? During expansion, another thing will be changing in the diameter of the superior vena cava, inferior vena cava. Expansion, lung is also expanding, thorax is expanding. They will also cause expansion of the diameter of the superior vena cava and inferior vena cava within the thorax. As a result, diameter is more, so more blood will be entering into the right atrium, isn't it? So, respiration, during inspiration, venous return can be increased. Now, if there is increased venous return, where this blood will go? They will enter into the ventricle. So, there will be stretching. So, this will be, now with more force it will be contracting, more cardiac output will be there. So, that's why during inspiration, cardiac output will be, venous return will be more. As a result, stroke volume will be more. As a result, cardiac output will be more. So, this way respiration affects. Again, during expiration, what happens? Diaphragm is moving up. It is coming to its normal position. Inside, in the thoracic pressure is rising. As a result, SBC, and inferior vena cava, superior vena cava, they are again coming to its narrowed, so less blood will be coming than previous, so less blood will be coming, less cardiac output will be, less venous return will be there, so means less cardiac output will be there. So this is how our respiration also affects cardiac output. Next, come to the muscle pump. Think of this. I am contracting my calf muscle. So within the calf muscle, there are some blood vessels, veins. Now these veins are having valves. Is open in one direction towards this. Okay. The calf muscle is relaxed. This is the vein. Here is one valve, here is another valve. Okay. So blood is moving this way. Now what is this muscle is contracting? This muscle is contracting. As a result, the blood vessel will be compressed. If the blood vessel is compressed, where the blood will go? Can it come? It will try to enter this way, but the valve will be closed, will be closing, so it cannot enter. Then it will try to move up with this pressure. Those valves will be open and the blood will be moving upward. Okay, so my muscular activity, if I do it regularly, so this muscle will act as a pump. When it is relaxed again, this blood will try to enter. The blood will be closed. Now, what will happen? This blood will be entering here. This blood will be entering here. Again it will be contracted. When the muscle will be contracted, again it will be pumped. In this way, by doing this thing, I can increase the venous return. Is it okay? Is that right? So in this way, we can increase our venous return by pumping action. This is the pumping action of the muscles. Next, come to cardiac pump. Cardiac pump. Visa targo and visa fronti. Visa targo, visa fronti. The pump, cardiac pump, it has visa targo means pressure from behind, and visa fronti pressure on the before at the front, pressure at the front, pressure at the back. So these two forces act on the heart. What is the first one? One force is pushing the blood to the heart. So because of the push or pull or suction, actually it is the suction pressure. Because of the suction, blood is entering into the right atrium. Okay? Again, this is what I mentioned, two terms. One is, the term I used, visa fronti or visa back. That is at the back. At the front, at the back. So, because of one pressure, some amount of blood is coming. It is actually pulling, and again I am sending at the front. Some pressure is there. So to overcome this pressure, I am contracting. So by this because of this pressure and because of pressure within the heart, I am creating to overcome those pressure in the aorta. So this is visa fronti. Pressure in the aorta, visa fronti, and the return of venous return, the pressure by which venous blood is entering into the heart, that is the pressure at the back. So now the heart is acting as a pump. So three pumps we understood. One is respiratory pump, another is muscle pump, another is cardiac pump. Blood volume, it is very simple. You are having 5 liters of blood. So with this amount, your cardiac output is 5 liters per minute. if your blood volume is increased by any means, what will be happening? Whether cardiac output will be increased or decreased? Definitely cardiac output will be. This is directly proportional. If more blood volume, more cardiac output will be there. This all the blood has to be circulated, no? All the blood has to be. So every time you have to send more blood. So cardiac output will be increased by increasing blood volume. Next, venous pressure. Venous pressure, you will see, because of the venous pressure, venous return is increased. There is venous return. In the vein, what is the pressure? It is around in the venule. In the venule, if the pressure is around 22 millimeter of mercury in the venule, then from venule veins, in the veins it is less than this 22. Okay, then in superior vena cava it is 5.5. In the ventricle it is 4.5. So gradually this pressure is decreasing. Now we know blood flows from high pressure to low pressure region. Where is the high pressure? In the venule. It is around 22 millimeter of mercury. So in the superior vena cava, inferior vena cava, how much it is? 5.5. So lot of pressure difference. So as a result, blood will move from higher pressure to lower pressure. And from the superior vena cava to ventricle, in ventricle it is 4.5, means not ventricle, in right atrium it is 4.5. Normally it is 4.5, but during at the end of the auricular systole it may become 0. So as a result, what will be there? From periphery, from venule, there will be movement of blood towards the right atrium. So it is this factor. What is this? Venous pressure. So venous pressure favors venous return. So if venous pressure gap is more, then more venous return will be there. It happens in exercise. More venous return means there will be increased cardiac output. Okay, then gravity. We have explained during gravity. So because of gravitational pull, if particularly in elderly person, if the person remains for long hours in a standing posture or in a sitting posture, there will be accumulation of blood in the legs, swelling of legs. Means this is what? This peripheral swelling in the swelling. We know the veins are capacitance vessels. Okay, they are very compliant. Means what are compliant? By applying less pressure, you can have more distension. Okay, that means the veins will be having less lateral pressure since their wall is thin. So because of wall is thin, and so their contractility is relatively less. So they can accommodate, because of this, they can accommodate more blood. Do you know? 3/4 of your blood, 3/4 of your total blood always remains in veins. If you are having 6 liters of blood, how much blood will be retained in venous system? 3/4. Divide 6 by 3, by 4, or say 8. Suppose you are having 8 liters or 4 liters. 3 liters will be in venous system, 1 liter will be in arterial system. So how it can accommodate? Because of its compliance. Okay, you want to, so it is the storage. It remains when there will be hemorrhage, no? So there will be lot of loss of blood. Okay, now how you will survive? Then this 3/4 blood, this wall of these veins will be contracted by the sympathetic system. So as a result, they will be contracted. So this additional stored blood will be coming into circulation. Will participate in circulation. Okay, so there then storage will be less in veins. In that case, it may be half of, not 3/4, half of the total blood. So in this way, gravity also affects venous return. Now the sympathetic tone, I have already explained in this case, always the sympathetic nervous system they are always sending impulses to the veins, to the veins. Veins in the veins means in the wall of the veins, means in the wall what is there? Smooth muscles. So this sympathetic tone, they will be contracting the smooth muscle. As a result, smooth muscle will be contracted, and this contraction will help more blood to be sent from more blood will be coming to the return to the heart. Veins will be contracted. Where this blood will go? To the heart. This is means venous return. So by increasing venous tone, we can increase the venous return. Next, what is this? AB pressure difference. AB pressure difference. Arteriovenous. It is about arterial and veneal. The pressure difference is 10. So because of this 10 millimeter of mercury pressure difference, where it is less, in veneal it is less, in artery it is more. So blood will flow from arterial to veneal. So this is one. If the pressure difference is more blood will be entering into the veneal. But it will, in that case, we exchange time, in the capillary exchange time will be less. And ventricular compliance, we have already discussed, given the example in case of coronary infarction. So infarcted area, if survives, the patient survives, infarcted area will be replaced by the fibrotic cells. The fibrotic cells are not having contractility. As a result, the ventricle will lose its contractility to some extent. So their cardiac return, venous return, cardiac output, this will be less. So these are the factors that will be affecting venous return. Now heart rate. So you can see, since it is the product of heart rate and stroke volume, you can see this is the relation. If I increase the heart rate, what will happen to the cardiac output? See, if I increase the heart rate, initially there will be increase in cardiac output. But in this level, in this case, what is the heart rate? 50 to 150. During this heart rate range, initially cardiac output will be increased. Thereafter it will remain same, and then it will start to fall. Why it is falling? Heart rate is increasing because stroke volume is decreasing. At this high heart rate, stroke volume is decreasing. Why? Systolic, and this is the period of diastolic. Diastolic time is more. It is 0.3 second normally, and it is 0.5 second. When we increase the heart rate, definitely this cardiac cycle length will be shortened, isn't it? 60 divided by heart rate. 60 the second divided by heart rate. If heart rate is more, this cardiac cycle length will be less. We will be gradually more increasing the heart rate, means cardiac cycle length will be decreasing. This means it will be shortened. This means time for systole will be shortened, time for diastole will be shortened. Okay, but to some extent, to this is not affected. Systolic time remains constant almost, but cardiac cycle length is reduced at the cost of diastolic time for diastole. That is, now this 0.5 second will be gradually decreasing. What does it mean? Diastolic time is decreasing, means less filling time. During diastole, what happens? Blood is entering into the ventricles. So this time is lessened. As a result, less blood is entering. So if less blood is entering, there will be less stretching. So there will be less contraction. that means stroke volume will be reduced. So if stroke volume will be reduced, heart rate is increased. Suppose stroke volume reduced to 50 ml and heart rate increased to 80 or 90. What will be the product? What will be the cardiac output? 90 into, what is the result? How much? 4.5. So it is less than 5 liter. So it is less than 5 liter. So if it is, time is lessened, if time is reduced because of increase in heart rate, what will be? There will be filling time is less. So as a result, less blood will be time for filling is less. So less stressing, less stroke volume. So stroke volume into heart rate, it may be more than, it may be less than 5 liters. Here it happens. Here it happens. There is two shortening of the relaxation time. As a result, total cardiac output is reduced. When it happens, when it is, heart rate is more than 150. So this way, heart rate can affect cardiac output. Peripheral resistance, we have already told, if in the arterial system, peripheral system, more resistance is there, so there will be what? It will be difficult to eject the blood into the circulation. So it will more circulation, it will send less blood, means stroke volume will be reduced. If stroke volume is reduced, cardiac output will be reduced. And force of contraction, we have already discussed the Starling's law of heart. If more stressing, more force will be there. Okay, so this effect we have already discussed. Neural regulation, sympathetic nervous system and parasympathetic nervous system. We have already the hormonal effect we have already told. So that these are the ways by which cardiac output is controlled.